Welcome to this explainer on the clinical utility and diagnostic thresholds of non-sedated flicker ERG in pediatric nystagmus. Today, we're diving right into the recent findings from the Grace et al. Study. Look, evaluating infantile nystagmus is frankly one of those unique and frustrating clinical hurdles we all face. Since we know sensory pathway abnormalities are driving over 90% of these cases, we absolutely need functional retinal data to get to an accurate diagnosis. Now, while full-field ERG is our undisputed gold standard, you know the practical challenges all too well. Dark adaptation, contact lens electrodes, and most critically, the neurodevelopmental risks tied to general anesthesia. All these logistical hurdles just end up delaying our ability to nail down a definitive diagnosis.
So let's look at Section 1, ERG pre-assessment and a streamlined approach.
The study evaluated a pre-assessment methodology using a handheld device with non-invasive skin electrodes. What's interesting here is that this objective approach doesn't require eyelid specula or contact lenses, which fundamentally reduces patient discomfort right at the point of care. In terms of the protocol, it records ICSCV-compliant 30 Hz cone flicker responses. It utilizes a 28.3 Hz frequency to specifically isolate those cone-mediated responses. It only takes about 10 seconds per eye. It's done entirely in room light, and it achieves high reproducibility through signal averaging.
Moving on to Section 2, let's talk about the study results regarding clinical feasibility. Researchers looked at a prospective cohort of 71 pediatric patients. And in this group, they found that the non-sedated approach actually achieved a 92% success rate in securing reliable, objective ERG measurements. Pretty solid for this patient population.
Even better, the study found this methodology to be highly effective at discriminating retinal dystrophy from non-dystrophy nystagmus. The data showed an AUC of 0.986, which is an incredibly high accuracy for this distinction. This brings us to Section 3, Diagnostic Thresholds and Actionable Insights. For daily clinical practice, the study identified some very clear thresholds. If you're seeing an amplitude of less than 5 microvolts paired with an implicit time greater than 33 milliseconds, that warrants a high suspicion of retinal dystrophy. Also, an unmeasurable implicit time was seen in 67% of the confirmed cases, so that's a major red flag. On the flip side, an amplitude of 2.54 microvolts or higher suggests a greater than 90% probability of normal cone function. Now, obviously, we have to look at the limitations here. The study cohort was relatively small, just 71 patients. We also don't have data on infants under 6 months of age, and since this is a cone-only protocol, we have to remember that conditions like CSNB might just be missed altogether. Let's wrap up with Section 4, optimizing the pathway for streamlined care. It's important to note that the study positions this methodology not as a total replacement for full-field ERG in complex cases, but rather as a critical pre-assessment tool. After your initial clinical exam, this step helps guide that decision tree. It clarifies who needs immediate genetic testing, who truly requires that escalation to a sedated ERG, and who can safely just be monitored. So, the big takeaway question is this: how will integrating an evidence-based pre-assessment like this optimize safety and scientific rigor in your own pediatric pathway? By bridging the gap between standard exams and high-risk sedated testing, this study outlines a clear way to streamline those tough diagnostic decisions, all while mitigating neurodevelopmental risks for our youngest patients. Thanks for joining me for this explainer.